The number of coronavirus infection cases, better known as COVID-19 disease for coronavirus disease 2019 is the year. The number is increasing as we talk, and it's almost gone beyond 700,000 confirmed cases worldwide, with almost 34,000 deaths. The recovered cases are close to 150,000. Most of these cases are centered around Europe and North America, especially in the US. And as you know, it all began from Wuhan in China and spread worldwide. So, welcome to an update on SARS coronavirus 2 infection, some interesting facts, and a pathophysiology review. And this video is especially for my pathology course students, plus all the other medical course students, to help them review some important concepts related to this topic. I am Dr. Samal Noria. I teach pathology at a medical school located in the beautiful Cayman Islands. So, today I want to share some in depth medical knowledge about this virus, specifically on the pathogenesis of this viral disease. And I shall also discuss some proposed treatments and vaccine production. So, I'll discuss a few points from the historical background of this infection, the pathogenesis, proposed treatments, some prevention tips, and a few future interesting facts related to this coronavirus infection. Till date, three highly pathogenic human coronaviruses have been identified so far, including severe acute respiratory syndrome, better known as SARS coronavirus or SARS-CoV. Another is the Middle East respiratory syndrome coronavirus, known as MERS coronavirus or MERS-CoV. And now we have the 2019 novel coronavirus, known as 2019 nCoV, as previously termed by the World Health Organization. So, among them, SARS coronavirus was first reported in Guangdong in China. That was in the year 2002. And this SARS coronavirus caused human to human transmission and resulted in the 2003 outbreak, which had about 10% case fatality rate. The MERS coronavirus was reported in Saudi Arabia in June 2012. Even though with its limited human to human transmission, this virus showed a fatality rate of up to 34.4%. And now we have this 2019 novel coronavirus reported from Wuhan, China in December 2019 from patients who experienced illnesses like pneumonia, and then it exceeded both the SARS coronavirus and the MERS coronavirus in its rate of transmission among humans. The good news now is that we have advanced biotechnology, better understanding of proteomics, and above all, we have advanced quantum based supercomputers. And so I think we have a better, chance of fighting against this infection with these tools. Now, for this video, I shall focus on pathophysiology of this disease, some treatment options, and particularly what is the update on this. So let's begin by looking at the virus structure. So this is an RNA virus, which is a single-stranded RNA inside the virus and spikes on the surface that forms a shape of crown, and that is why we, call it as corona. So this virus infection created a disease outbreak in China in 2019, and so now we call it as COVID-19. This is the short for coronavirus disease 2019. Now, WHO has official scientific name for this virus, which is SARS-CoV-2 for SARS coronavirus 2. This is like a second generation virus of the SARS, and probably this is a mutated form of the original SARS virus, which is 1000 times more infectious than SARS. Let's look at how does this spread. So typically one person could infect 2.6 others by primarily droplet containing viral particles. The structure of this virus is very interesting. In general, this coronavirus contains four structural proteins that we need to know. These include spike or the S protein, E is the envelope, M is membrane, and N is the nucleocapsid proteins. Now, among these, S protein plays the most important roles in viral attachment, viral fusion, entry, and it would serve probably a target, for development of antibodies or entry inhibitors or vaccines. Now let's look at something more about this S protein. So this S protein mediates viral entry into the host cells by first binding to a host receptor through the receptor binding domain, which is in the S1 subunit, and then fusing the viral and the host membranes through the S2 subunit. Now, this virus recognizes an angiotensin converting enzyme 2 as its receptor. Now, what it does is it hijacks this ACE2 enzyme or this receptor along with a serine protease known as TMPRSS2, which is short for transmembrane serine proteases. These are present on the cell surface and help the virus to internalize into the cell. Now, a key question is why the lungs appear to be the most vulnerable target organ. So, one reason for this is the vast surface area of lungs makes the lungs, highly susceptible to inhaled viruses. Another is the biological factor, which is the ACE2 receptor or the ACE2 enzyme. This is highly expressed on the alveolar epithelial type 2 cells. Now, an interesting fact here is that this ACE2 is also highly expressed on the luminal surface of intestinal epithelial cells, and it functions as a co-receptor for nutrient uptake, in particular for the amino acid resorption from food. It is being actually predicted now that the intestines might also be a major source of entry for this SARS coronavirus 2, and the infection might have been initiated by eating food from the Wuhan market, the putative site of the outbreak. So now we have discussed about this ACE2. So it's good here to mention about the RAS pathway. You all might have learned the RAS pathway in physiology and how it regulates the blood pressures. And as we are now discussing about the angiotensin converting enzyme too, so it's better that we review this RAS pathway and see how ACE and ACE2 regulate this pathway. Now, according to the traditional view, angiotensinogen produced by the liver is converted into angiotensin through the action of renin. Now, this is an enzyme synthesized by the cells of the juxtaglomerular apparatus of the kidney. Now, subsequently, angiotensin 1 is cleaved by angiotensin converting enzyme or the ACE, which generates angiotensin 2. Now, angiotensin 2 exerts its effects by binding to two G protein coupled angiotensin receptors. Now, circulating angiotensin 2 is the main effector of this RAS pathway, and this is what is involved in the global regulation of sympathetic activity and blood pressure, as well as fluid and electrolyte balance. Current understanding of the RAS actually is based on that the two enzymes ACE and ACE2 they counterbalance each other. So ACE2 is a zinc metalloprotease which is homologous to ACE. Now this converts angiotensin 2 directly into angiotensin 1,7. It also generates angiotensin 1,9 from angiotensin 1 by hydrolysis. So angiotensin 1,9 can also be cleaved by ACE, resulting in angiotensin 1,7. However, angiotensin 1,7 is mostly produced through the action of ACE2 on angiotensin 2. So this angiotensin 1,7 binds to a specific receptor named as MAS receptor, which is also a 7 transmembrane G protein coupled receptor. Now, this interaction of this angiotensin 1,7 with MAS receptor triggers intracellular mechanisms and functional events that are in general opposed to the actions triggered by angiotensin 2. Now, also the angiotensin 1,9 interacts with the angiotensin type 2 receptor. So both these MAS and angiotensin type 2 receptors they will cause vasodilatation, which will lead to reduction of blood pressure, inhibition of cell growth. These have both antithrombotic effects as well as anti-inflammatory and antifibrotic effects. So basically, ACE2 lowers blood pressure by catalyzing the cleavage of angiotensin 2, which is a vasoconstrictor, into angiotensin 1,7 now, which is a vasodilator and also causes a decrease in pro-inflammatory cytokines like TNF alpha and interleukin 6. Now let's look at this concept in application to SARS coronavirus 2. Now this same ACE2 serves as the viral entry point into the cell. Therefore, an understanding of this interaction of the receptor binding domain, which is present in the SARS coronavirus 2 S protein along with the ACE2 receptors, is very critical as these are likely the targets for development of virus attachment inhibitors or neutralizing antibodies or even future vaccines. So one thing to note here is that this ACE2 is not inhibited by captopril or other classical ACE inhibitors. On the contrary, angiotensin receptor blockers and ACE inhibitors, they actually increase the levels of ACE2. Now, it's good to review some drugs here. So, angiotensin receptor blockers include drugs like losartan, telmisartan. ACE inhibitors include enalapril, lisinopril, etc. Now, a big question arises here. Somebody might ask you, should I stop taking these antihypertensives? So, the clear cut answer as of now is that there is no clear age adjusted data to prove that. There is just some preliminary data from Italy and China, and not many clinical trials have shown any solid proof. A recent paper published on COVID 19 and all these antihypertensives talks about any evidence, if there is, that these could worsen the disease. So it clearly mentions that there is no clinical or scientific evidence to suggest that treatment with ACE inhibitors or angiotensin receptor blockers should be discontinued. Also, this paper suggests that there is insufficient clinical or scientific evidence to determine how to appropriately manage hypertension in the setting of COVID 19. Another recent paper on these drugs warns against abruptly stopping these medications as it could lead to serious harmful health situations. A recent paper published in The Lancet talks about how ACE2 can also be increased by thiazolidine and ibuprofen, and how ACE2 expression is increased in diabetes, and treatment with ACE inhibitors and angiotensin receptor blockers increase ACE2 expression. So, increased expression of ACE2 would, of course, facilitate infection with COVID 19. Now, diabetes and hypertension treatment with ACE2 stimulating drugs, it says, increases the risk for developing severe and fatal COVID 19. ACE2 polymorphisms have also been linked to diabetes mellitus, cerebral stroke, hypertension, and this is specifically seen in Asian populations. Combinations of both therapy and ACE2 polymorphism might in future, give us more information about how this infection actually affects different populations. Another is patients with cardiac diseases, hypertension, or diabetes who are treated with ACE2 increasing drugs. They are at higher risk for severe COVID 19 infection and therefore should be closely monitored. Another TMPRSS2 inhibitor, which is approved for clinical use, blocks the viral entry into the cell, and this might constitute a treatment option. So the drug is chemostat mesylate. This is an inhibitor of TMPRSS2, and this potentially blocks SARS coronavirus 2 infection of the lung cells. Now let's look at how SARS coronavirus 2 replicates itself in the cells of those who are infected. So the first step is that the spike or the S protein on the virus binds to ACE2, which is a cell surface protein. Now, as we have discussed, TMPRSS2, an enzyme also on the cell membrane, helps the virus to enter the cells. Now, the second step is that the virus releases its RNA, and further, this RNA is translated into proteins by the cell's machinery, and some of these proteins form replication complexes to make more RNA. So, finally, proteins and RNA are assembled into a new virus in the Golgi apparatus, and the last step is all these viruses are reassembled and released. Coming to the clinical features, now the incubation period for COVID 19 is thought to be within 14 days following exposure, with most cases occurring approximately 4 to 5 days after exposure. And the typical symptoms, they include fever, dry cough, and fatigue. Now, a paper published by the New England Journal of Medicine is a study on 1099 lab confirmed cases of COVID 19 taken from 552 hospitals in 30 provinces from China. The median age of the patients was 47 years, 41% of the patients were females. Fever was found in 43% cases, cough found in 67.8%, and a median incubation period of 4 days was noted. Another paper published by the Journal of American Medical Association talks about the report from 72,314 cases. So if you look here, 44,672 out of these cases were confirmed cases of COVID-19. So confirmation here was a positive viral nucleic acid test, which was a result from the throat swab samples. Age distribution data shows 3% cases were of age group more than 80 years, with most of the cases showing a mild disease, that is 81%. Severe cases reported in the study are 14%, whereas critical cases only 5%. The case fatality rate overall presented in this paper is 2.3%. Most of the cases here were classified as mild with just pneumonia like symptoms. 14% had severe illness, and 5% were critical with respiratory failure or shock. Acute respiratory distress syndrome is a major complication in patients with severe disease, so it's good to review a few key points about ARDS. Now, in ARDS, the integrity of the alveolar capillary membrane is compromised by endothelial or epithelial injury. So, alveoli are the ultimate site of gas exchange. As you all know, the alveolar walls, they consist of following components proceeding from blood to air. Now we have the capillary membrane endothelium, then we have the basement membrane and the pulmonary interstitium, which is composed of fine elastic fibers and small bundles of collagen, some fibroblast like cells, smooth muscle cells, some mast cells or rare mononuclear cells. Alveolar epithelium consists of a continuous layer of two principal cell types. Now, this is flattened plate like type 1 pneumocytes, which cover 95% of the alveolar surface, and the others are rounded type 2 pneumocytes. These type 2 pneumocytes synthesize pulmonary surfactant and are the main cell type involved in repair of alveolar epithelium after damage to type 1 pneumocyte. In this image, you can see the normal alveolus on the left and the injured alveolus on the right side, which is in the phase of acute lung injury and ARDS. Now, under the influence of pro-inflammatory cytokines like interleukins IL-8 and IL-1 and TNF, which is released by macrophages, neutrophils are sequestered in the pulmonary microvasculature and then they egress into the alveolar space where they undergo activation. So activated neutrophils are going to release leukotrienes, oxidants, proteases, platelet activating factors. Now this all contributes to local tissue damage, accumulation of edema fluid. They will inactivate the surfactant and eventually this will lead to a hyaline membrane formation. Now, this hyaline membrane is known as the pink membranes, which is formed along the alveolar walls and is like a thick pink membrane blocking the exchange of gases, and also there is a lot of fluid accumulation. Subsequently, the release of macrophage derived fibrogenic cytokines such as transforming growth factor beta and platelet derived growth factor, they stimulate fibroblast growth and collagen deposition, which is associated with the healing phase of injury. Here you can see the evidence for diffuse alveolar damage, which is seen in the acute phase. Now some alveoli are collapsed while others are distended here, and many of the alveoli are lined by these bright pink hyaline membranes. Whereas this second image shows you the healing stage. Now this is marked by resorption of those hyaline pink membranes and thickening of alveolar septa occurs due to inflammatory cells, fibroblasts and collagen. And there are numerous reactive type 2 pneumocytes which are shown by these arrows, and this indicates regeneration and repair of alveoli. Imaging finding, particularly chest CT in patients with COVID-19, most commonly would demonstrate ground glass opacification, maybe with or without consolidative abnormalities, which are consistent with viral pneumonias. Now, clinical suspicion and criteria for testing should be possibly applied to those patients who primarily present with new onset of fever or respiratory tract symptoms like cough and dyspnea. Another could be a patient who resides in or has traveled within the prior 14 days to a location where there is community transmission of SARS coronavirus 2. Another situation could be that he had had a close contact with a confirmed or suspected case of COVID-19 in the prior 14 days. Now, how do we define this close contact? So, close contact includes being within approximately 6 feet, that is about 2 meters, of a patient for a prolonged period of time while not wearing any personal protective equipment or having direct contact with infectious secretions while not wearing any personal protective equipment. For lab testing in the United States, the CDC recommends collection of nasopharyngeal swab specimen to test for SARS coronavirus 2, and the SARS coronavirus 2 RNA is detected by reverse transcription polymerase chain reaction known as RT-PCR. So before we look at the treatment and vaccine options being tested today, it is good to know that some people who have died from this disease have shown to have a low T cell and a natural killer cell count. Now, one study shows that the number of T cells, CD4 cells, CD8 cells were dramatically reduced in COVID 19 patients. Especially, this was seen among elderly patients more than 60 years of age and patients who required ICU care. So, basically, we are trying to understand the host immune reactions to this virus. So this brings us to the treatment options that we are looking at. So first is blocking of the ACE2 receptor, and the good news is that we have a very good understanding of this ACE2 receptor. Second option is blocking machinery in the cell. Another could be blocking packaging of the virions. Another is basically activating natural killer anti cells, which produce a lot of granzymes and could induce apoptosis in the virus infected cells. Some of the drugs currently being used are remdesivir. So this shuts down viral replication by inhibiting a key viral enzyme, that is the RNA dependent RNA polymerase. Another is chloroquine and hydroxychloroquine. So there's a lot of demand for this chloroquine and hydroxychloroquine, which are the decade-old anti-malarial drugs. Next combination of drugs is ritonavir or lopinavir. So these drugs inhibit the protease of HIV, which is an important enzyme that cleaves a long protein chain into peptides during the assembly of new viruses. Now, because lopinavir is quickly broken down in the human body by our own proteases, it is actually given with low levels of ritonavir, which is another protease inhibitor, and that lets lopinavir persist a little longer. Another combination is ritonavir, lopinavir along with interferon beta. So basically this is combining two antivirals with interferon beta, which is a molecule involved in regulating inflammation in the body. Finally, some prevention tips include hand washing. So soap removes virus from the hands. It acts as basically a surfactant. Now keeping in mind that 20 seconds are required to create this interaction between soap, and that is how the soap will help lifting off the virus from the surfaces. Enveloped viruses are actually vulnerable as the soap can crack open the envelope. Second prevention tip is social distancing. So basically, this is maintaining a minimum distance of 6 feet from each other. Now, some future research is still going on to identify various patterns of this disease. One of them is identifying various patterns of this disease in people of various blood groups. One of the studies has showed that there is more infection in blood group A and there is lesser evidence of infection in the blood group O. Another study looks at if there is some variation in, this disease expression related to temperature, like hot, humid, or cold temperature. Another question is what is the relationship of ACE2 polymorphisms? Is there any role of BCG vaccine? Is BCG vaccine protective? Is this disease more severe in men? Is there a fecal-oral transmission route possible? If it could be spread by pets? So there are a lot of questions still unanswered and a lot of research is going on, and I shall be very happy to update the information in another video when there is enough evidence available. Thank you so much for listening to this, and please subscribe to this channel for the latest updates. Thank you.